Hello, everyone, and welcome to today's Coffee and Chai Chat. My name is Martin Mwangi. I am the program lead of the Healthy Mothers, Healthy Babies Consortium, which is hosted by the Micronutrient Forum. Today, we have a very interesting lineup of presenters or speakers, and we also hope that from wherever you're joining us, that you're going to pay keen attention and prepare nice questions for them. First, we will hear from Emily Mates, who is the maternal nutrition specialist at UNICEF HQ. And then we are also going to hear from Philip James, who is a senior associate, technical associate at the Emergency Nutrition Network. We are going to be speaking about UNICEF's plan to fast-track multiple micronutrient supplementation in countries as part of the strengthened antenatal care services. And then we are going to also hear from ENN's work about MMS in emergencies and how we can transform maternal nutrition in emergencies and beyond. You may be aware of the issues that have been going on recently about in the sphere of maternal nutrition and MMS. But before I talk about the investment roadmap for maternal nutrition and MMS, I want to first give some housekeeping instructions. So first of all, please write your name and affiliation in your Zoom window and turn on your video. And note that all participants will be muted during the presentation, but will be able to unmute themselves during the Q&A. Remember to raise your hand if you would like to ask any question. You are also welcome to use the chat box to ask questions. And in case you have any technical difficulties, kindly send a direct message to tech support. You can do that in the chat function. And please note that this meeting is being recorded. And so you might get a pop-up. Just click OK in the pop-up that comes on your screen. And recently, towards the end of last month, the Healthier Pregnancies and Brighter Futures for Mothers and Babies Global Investment Roadmap for MMS was launched by partners. And what is really encouraging about this initiative is that we have an alignment of not only funders, but also implementation agencies, key resource persons in maternal nutrition, all agreeing that it's time to invest in maternal nutrition, it's time to fund maternal nutrition, and committing or pledging funds to at least make sure that women around the world go on to access multiple micronutrient supplements. This roadmap is available on our website, and you can download it, and you will at least get to read more about MMS. You will read the plans that are there to invest in multiple micronutrient supplementation, the plan to deliver MMS to over 260 million mothers and their babies, and see how your country or your organization could position itself to be able to access this, or rather inform this roadmap, access the resources that are available, and link up with various resource persons. Now, going on for this coffee and chai chat, I will hand over to Phil James, who will steer the conversation. And remember, our coffee and chai chats are usually an exchange, so keep your video on if you can. It's more of an exchange between Phil James and Emily. And then after they're done with the formal part of the exchange, they will open up for your own questions, and you can interact with them, and we can then at least get ourselves informed about the plans everyone has on about MMS and maternal nutrition. Phil James, over to you.
Thanks so much, Martin. Thank you for your kind introduction and for inviting us to participate with you and with everyone here. So today I'm taking more of an interviewer and facilitator role, where I'll be primarily chatting with Emily from UNICEF. And just to let you know the rough outline, we'll talk about the UNICEF acceleration plan for maternal nutrition for about 10 minutes or so. Then we'll come to some of ENN's resources that Martin mentioned for 10 to 15 minutes. And we will then indeed open up for wider questions from yourselves. So we'd like to primarily use the chat box for now for questions, just to try and get through as many questions as we can at the end. So please do feel free to put your questions in the chat at any time, and Rajuta will kindly be relaying them to me. And just before bringing Emily in, I just briefly want to show you some of the resources that are informing our talk today. So Gurmeet, if you could please share the slides, and we'll put the links in the chat as well. So we're starting with the UNICEF's Maternal Nutrition Acceleration Plan, which was launched last month in May. And on the next slide, then we'll be coming to ENN's state of play of MMS programming in humanitarian emergencies, and that was published in March this year. And then on the two next slides, informing that state of play, we have the in-depth case studies from Pakistan. That was from May. And then on the last slide, Somalia, our case study published in February. Thanks so much. We can stop sharing that now. And Emily, I'll invite you to join us. Welcome.
Thank you. Hi, Phil. Nice to see you. Nice to see everybody.
Brilliant. And first of all, Emily, before we get going, let's pretend we're meeting in a cafe in person, which would be wonderful for this chat. What would you be ordering right now? Coffee or chai, or maybe something a little bit different?
No, it's 9 a.m. in New York, so it's definitely coffee in the morning for me. Thank you. Chai the rest of the day, but coffee in the morning. Yeah. How about you, Phil? What are you going to have?
It's post-lunch for me, so definitely chai time. Yeah, it's great to see you. And you've been coordinating the acceleration plan for maternal nutrition at UNICEF together with your team. So for those people who maybe haven't read the report recently, please could you just start by outlining the plan in a nutshell for us? That'd be great.
Sure. Thanks very much. And thanks for introducing it so nicely. Yes, so you'll have seen from the slide that we launched this acceleration plan for improving maternal nutrition in March, actually, this year. It's quite an ambitious plan. We've gone for 16 countries with 16 million women, aiming to reach them by the end of 2025. And the reason this plan has come about is that there's, as Martin mentioned, there's been some momentum around women's nutrition and maternal nutrition recently, which is great. You know, I've been working in this field for, I think, nearly 25 years, and there's never been this level of interest or momentum around women's nutrition. So we wanted to sort of harness that momentum and capitalize on it as much as possible. So yeah, and part of what's driving this momentum is the excitement around MMS, or multiple micronutrient supplements, which is great. You know, it's a new improved product. It's fantastic. But what we wanted to make sure was that we utilize this opportunity of this improved product and help ensure that it's embedded in quality antenatal care services, so that it's used as a lever or a catalyst to help improve the whole pregnancy experience, not just some better prenatal vitamins. And the reason we're really, you know, trying hard to make sure that this plan gets rolled out and works well is that, as everybody knows, IFA, or iron and folic acid, has been around for many years, and it's generally understood that, you know, coverage is around 40% globally, but adherence is around 30%. And the barriers to IFA uptake and coverage go way beyond the side effects that we're all familiar with, because IFA isn't terribly well tolerated during pregnancy. So some countries that are included in the acceleration plan have already made good progress in starting to sort of transition from IFA to MMS. They've done implementation research projects, or they've you know, worked on updating policies, have done small scale projects. Some of the countries that are included haven't yet, and it's all quite new. But what we're hoping for with this acceleration plan, and what we've really based it around, is a learning agenda. So this isn't a proof of concept of the effectiveness or superiority of MMS over IFA. That's been done multiple times in many
Yeah.
clinical studies across the world. So that we're not trying to say that we're proving MMS is better. What we're trying to do is a proof of concept of how to take it to scale, because countries are
Right.
ready and it's ready to go to scale. And we want to be able to show that this is how you take it to scale while, using it as a lever to improve antenatal care services. Yeah.
So it's a big plan. It's ambitious, but it's really clear, I think, that MMS programming absolutely is a focus area, but it's part of this wider package of care for ANC services, which is fantastic.
Yeah.
What would you say?
Just to say, sorry, on the package,
Mm,
because I've had quite a few questions of people
yeah.
saying, why have you,
What is it?
selected 5 of the, because as all of you know, there's 16 nutrition recommendations in the WHO's antenatal care guidance.
Mm,
And if countries can implement all 16, then that's fantastic. Absolutely, that's ideal, that if they can all be implemented. But what we were looking at were what was the absolute minimum that really needed to be in place for
right.
this transition to MMS to be successful. So we've selected 5 that we say, they really have to be in place for this transition to be successful, to introduce MMS, because MMS is the one that's ready, really ready to go to scale. So that's why we've selected the 5.
So kind of critical minimum, absolute minimum package. Brilliant.
Exactly. Yeah.
And when you think about this plan, what really excites you about it? But equally, what maybe makes you lose sleep at night? Well, hopefully you're not losing sleep. But some of the challenges that you foresee, be great to hear a bit more.
Okay. Yeah. So, I mean, there's a lot to be excited about, I think. As I said, the momentum, it's really is exciting. For years, many of us have been saying, what about the women? What about the women? As we've all focused on infant and child outcomes. And of course, they're critically important, but we all know we can't improve infant and child outcomes without looking at women's nutrition before and during pregnancy as well. And it's just very exciting to be able to hopefully make a real difference to the pregnancy experience and pregnancy outcomes, beyond the immediate effects of improved prenatal vitamins and so, protection from anemia and other micronutrient deficiencies, but really those sort of wider and longer lasting effects that improved antenatal care services will bring about for women and their families, because we believe it will really benefit the whole family. And just the getting researchers and programmers and practitioners to think about women in their own right and for their own sake is a very exciting time. As I said, there's been this long sort of focus on infant and child outcomes, which are really, really important. But each time I do an evidence review or look at the evidence, it's very interesting because most of the research really only focuses on the infant or the child. So it's quite exciting. And the other thing that's really exciting me is that once you start looking at women in their own right, it actually tends to get the whole conversation about gender and gender inequality more on the table, because
Right.
we start realizing and noticing, which is it's always been there, but that gender inequality, it contributes so much to poor nutrition across the life course, but also across families. So it's really quite exciting to be able to really focus in a bit on gender issues across many of these countries. So that's what I get excited about. What was your other question? What am I losing sleep on?
Well, yeah, some of the challenges, or maybe that will come up in it when we talk about the ENN report later on as well. But any that instantly comes to mind, any particular challenge you're foreseeing in
Yes,
all
I
this?
mean, at the moment, I mean, the supplies and getting enough supplies to where they're needed is definitely a challenge, and we spend quite a lot of time on calls around supplies
Right.
because at present there's not enough being manufactured for all this momentum, and we don't want to create all this demand and then find that actually you can't meet the demand. So that is a bit of a challenge, but we're working through that, and UNICEF Supply Division are doing a lot of work with a lot of suppliers.
Okay.
But that's definitely a challenge. I think the main challenge, and we probably will come to this when we talk about the ENN report, but it's trying to avoid or trying to steer off as much as possible of it just being a product-based approach. Because I think, we have a tendency across the nutrition sector, and I'm sure many other sectors are the same. You get a new product or a new innovation or a new toy, if I can be a bit rude and say it like that, that you think, oh, this is great and this is going to make, all the difference to women or children or whoever it is you're targeting. And the innovation is great, but it will only really work if you strengthen the delivery system around it. And if you strengthen, health service provision, particularly when we're looking at MMS, we're talking about health services because, it's during pregnancy, that's when most of the services are given through. But, all the other systems are really important as well, the food system, social protection, education. So I think we need to try and remember that it's not a software bug. It's the lack of a good prenatal vitamin isn't the only issue for improving pregnancy experiences and outcomes and birth outcomes, and that we really need to look at it in a holistic way and look at how we improve the delivery of it of the system itself. So strengthening health services around it, which is obviously much more difficult than just the magic bullet that will fix everything.
Presumably a lot harder to cost from the outset when we think about health workforce and remuneration difficulties, overstretch difficulties, how to cost that and really make a difference in the platform for service is tricky, I'm sure. But
it is, and I think the counselling aspect, because that's such a key part, and counselling is quite difficult to deliver well on so many levels. You need well-trained health staff. You need health staff to be supervised well. And often, as we all know, you go to various health clinics, and it's the same in high-income countries. It's not exclusive to low and middle-income countries. And the counselling that's being delivered is a bit more of a tick box exercise, somebody reading off a sheet or whatever, rather than it being that sort of interactive elements that you really need in order to affect any kind of social or behavior change. It's not just about giving information. We know that.
Yeah.
You can give information all you like, but that doesn't necessarily lead to behavior change. You have to actually, do more work and more interactive work. So that's certainly a challenging aspect of it. Yeah.
Absolutely. I think what you've been talking about, the wider health system strengthening, certainly, well, as you know, is a key theme in the ENN report, and maybe we'll move to that now. And we've got an overview video that is going to give you a little bit of an insight for those of you who've joined us today on what's inside the ENN report. It's our state of play on MMS in humanitarian emergencies. So we have ENN co-authors. Emily was also very much involved at inception, also as a co-author. But we'll switch now to the video, which is narrated by one of our authors, Kate Sadler.
Hi, I'm Kate Sadler, Technical Associate at the Emergency Nutrition Network. Welcome to this brief overview of ENN's latest report on the use of multiple micronutrient supplements, or MMS, in humanitarian emergencies. We know that women and girls are disproportionately affected by conflict and disaster. Due to their increased nutritional needs and vulnerabilities. Addressing their human right to adequate nutrition is critical, and daily multiple micronutrient supplements can play a crucial role in improving maternal and birth outcomes. However, there's extremely limited information on the extent to which women and adolescent girls receive MMS in humanitarian emergencies. Where MMS programming does exist in these contexts, details on implementation and barriers to successful scale-up are often lacking. This report aims to fill some of these important knowledge gaps. Information for the report was sourced from an online survey, 2 in-depth country case studies from Pakistan and Somalia, and additional key informant interviews. In this state of play report, we provide a brief background to MMS, summarising the key evidence and policies. We define humanitarian emergencies and also summarise the humanitarian system for nutrition programming. We present the results of the online survey and provide a short summary of the 2 case studies. The in-depth standalone case studies can also be found on our website. Finally, we pull together the key themes regarding barriers to and opportunities for the use of MMS in humanitarian emergencies. In the report, we cover the main points about the humanitarian system for nutrition programming in emergencies. We explain how it can be helpful to think about humanitarian response in 2 main categories. The first, international humanitarian action led by the nutrition cluster, and second, government-led domestic crisis management. This distinction, but also their overlap, is a key theme we explain in detail throughout the report. This quote sums up the realities nicely. Focusing on the international humanitarian system to understand how people survive and recover from a crisis is akin to viewing a large landscape through a pin-sized hole. We received a total of 131 individual responses to our online survey, representing 39 different countries. Respondents from 28 countries stated that they distributed MMS to women in humanitarian programs. Financing of MMS programming was the most commonly reported barrier across countries by a large margin, followed by 3 similarly ranked barriers: inadequate country policy protocols, inadequate supply chain, and inadequate awareness of benefits of MMS by health workers and target populations. We took the key findings from the survey, case studies, and additional key informant interviews and summarised them in the report by WHO Health System Building Block. This structure helped us to cover barriers and opportunities related to leadership and government, service delivery, financing, health workforce, supplies, and information systems. In summary, our findings suggest that whilst humanitarian emergencies undeniably present additional complex barriers to MMS programming coverage, what is needed to address them in these contexts remains fundamentally the same as what is needed in all settings, using the lens of health system strengthening to make MMS programming as effective as possible within quality ANC services. This report provides a snapshot of the state of MMS programming in humanitarian emergencies, but undoubtedly has not captured all relevant program experiences and contexts. Take a read and let us know your additional experiences and thoughts. Thank you to UNICEF, the Eleanor Crook Foundation, and the Department of Foreign Affairs Ireland for the generous support in funding this report.
Brilliant. So we've heard some of the key findings described by Kate in that video. And Emily, just to invite you back, are you there? What were some of the other key messages or maybe key themes that came out of the interviews and case studies that struck you in particular?
Well, I think we touched on them a bit earlier around the fact that you know, the health system strengthening aspect, even in, and not even in, even more in humanitarian emergencies where health systems might be compromised due to, you know, the situation that's going on. It's really important that that whatever services are there can be worked through as much as possible and strengthened and not undermined, but through the, you know, inadvertently undermined through the emergency response. So I think that was a key takeaway. The other thing was about the sort of domestic resource management of many emergencies in many countries. I think we often think, or at least I certainly sometimes think, you know, oh gosh, you know, an emergency happens and international organizations come in. But increasingly, countries are managing domestically at least a large part of the humanitarian situation, if not the whole thing. and therefore the international community's support needs to be tailored and adapted due to that. So yeah, I think those were really key takeaways. What I thought was very interesting, and Kate just described, reminded me there of the graph that, you know, funding and financing is the biggest challenge in humanitarian emergencies. But I think that could be, you know, sort of said wider as well, and that was one of the reasons why we're hoping the acceleration plan and the investment roadmap that Martin mentioned at the beginning helps to mobilize resources. We're particularly excited that UNICEF has the Child Nutrition Fund that I think many of the people listening here will know about, that was launched late last year, which is a match funding mechanism, which is a really great, and also we've learned a lot from the whole 20 years of scaling up wasting, that if you want to sort of make sure that there's some domestic resource mobilization as well, you need to do it at the beginning. You can't come in later, having funded everything and then said, oh, now we need domestic resource mobilization. You know, it needs to be really part of the planning from the beginning. So I think, you know, in emergencies, obviously, that's much more difficult. And there's obviously often there's less fiscal space for governments to be able to do some match funding. But it's certainly some lessons that we've learned and are trying to implement for scaling up women's nutrition. Yeah.
I found that it was quite difficult at the beginning to differentiate, you know, what's humanitarian emergency with, I guess there's increasingly a blurred line, isn't there, when we have protracted crises, conflicts, natural disasters, climate change exacerbating everything. And so what we find from our recommendations, I guess, doesn't necessarily look all that different from what we might look at the, you know, national or developmental level. And I think that's what really surprised me as well, was we've got key considerations that are particularly relevant for humanitarian emergencies, but they're not necessarily anything new or unexpected even. And that was nice that it came up kind of interview after interview, that we're looking at health system strengthening where that is possible. And I think something you said on kind of planning for the funding from the beginning, including the domestic resource mobilization, was brought up quite a lot as well, and taking a step back as well for when it comes to planning the response in the first place. So unless we articulate the nutritional needs of women and adolescent girls in the first place, get that clearly written into humanitarian response plans or, you know, government national plans, we're not going to see that fundraised for, let alone be implemented well. So I think just that critical need for data and to get that written into planning really came up strongly. It sounds obvious, but enough people said it to iterate that, you know, it's not happening necessarily, is it, at the moment?
Yeah. No, I mean, two things that come into my mind when you're talking about it. Firstly, about emergencies, the blurred line. It is a blurred line, and it depends which criterion you're using and all the rest of it. I mean, a couple of times recently, I've been trying to write a list of which countries are in humanitarian emergencies. But the other issue isn't just what the criteria is, but very rarely is an emergency across an entire country. Most of the time it's in a region or a district or a province or, you know, one pocket of the country rather than across the entire country. So of course, then the domestic management becomes even more important, because everything's still in place. The health service is still running, but perhaps not as well in the place that the emergencies happened. But it doesn't mean not usually, of course, there's some exceptions, but usually the whole thing hasn't collapsed. So we all need to be very conscious of working with governments and supporting them. The second thing you're saying about the funding and getting the data, because we've worked recently together, Phil, on the maternal nutrition guidance in humanitarian settings, which hopefully will be coming out in a couple of months. And that's something, again, that has really, really reiterated that the trouble is we don't really have good evidence for women. It's not very easy to say this works or that works because, as I mentioned earlier, most of the research studies, if women are included in them, it's actually infant or child outcomes that are measured. So it's critical that we start really looking at, well, what is working for the women? Because if the data's not there, then no, they won't then be included in the planning. And if they're not included in the planning, then they won't be funded for. And if they're not funded for, then they won't be programmed for, and round we go again. So it's absolutely critical that we collect as much data as possible for women. And that's, again, one of the main sort of rationales for the acceleration plan is to have this learning agenda so that we can really start saying what works and what doesn't for women so that we can fundraise for it in future.
Absolutely. I really liked how in your introduction to the acceleration plan, there was that emphasis on the learning agenda. And it's when I was asking myself as ENN, what can we do to support the acceleration plan? What can we do to support investment roadmap? All this momentum. And I think it's capturing what is working, what isn't working as well, equally important, so that governments or cluster leads don't start from scratch. And we have really good quality implementation research as well. We are both working on improving project evaluations and process evaluations, great quality implementation research that means we don't have to start from scratch when it comes to scale up. So I'm quite excited about that. And I think all of us here can presumably play a role in that learning, sharing experiences, context-specific experiences.
No, absolutely. I couldn't agree more. Yes, and I think if we all try and pull in the same direction, we'll get much further than if we're all So good coordination, supporting governments, speaking with the same voice, and sharing learning across contexts and countries. Because of course contexts have differences in them, but there are some fundamentals that are the same across anywhere, as we learned doing the humanitarian emergencies report with MMS. Really, most of the lessons are across all contexts, whether there's an emergency or not. You need the same things in place for a successful scale up.
Absolutely. So MMS as the lever, I liked that phrase, lever for quality ANC care. I'm just looking at the time, really want to give at least 10 minutes for opening up for questions. So do continue to post comments, questions in the chat. And Emily, we've got a question from Astrid, thank you, which is about, I don't know if you can speak to how UNFPA and UNICEF are working side by side to scale up MMS. How can both agencies strengthen collaboration within country policies? I guess that's bringing in the sexual reproductive health element. Can you speak to that?
Not hugely at the moment. We do need to, it's all been a bit hectic lately, but I know UNFPA do some great work in countries, and what we're going to be trying to do is look at country level what policies are in place and how they can be strengthened all at the same time, because there's great overlap, especially at country level, regarding all of the reproductive health aspects. So definitely
fantastic.
Factor.
Whilst we're waiting for any more questions, I don't know if Astrid, you wanted to directly share your experience on that. If there's anything you'd like to add, feel free.
Thanks. Yeah, no, I think it was, there was just a sense that we were sitting in different rooms where IFU was decided and then MMS, and I think, sorry, I thought I was muted. And then, just kind of wondering if, it just felt like we were convinced in the room that we should scale up MMS in this country that I was in. But then kind of in a different room, it was decided IFE was already being rolled out. So I think there was MMS in country, there was a will, but I think it felt like we needed some more collaboration, especially with between maternal health also within the different agencies in the ministries of health, so that it was very quite nutrition driven, whereas maybe we needed to have the reproductive health and maternal health parts, and maybe also education, if it's, we also want to bring in adolescent girls in this. So yeah, so I think it was just, and how that's, I guess it's not maybe more, not so much a question, but also comment. I think something that I saw, that how do we work better together on the scale up?
Yeah.
Because that was a big barrier. I saw that the will was there, the evidence is clear, but yeah. So, but great conversations.
I feel, yeah.
Yeah, big question, Astrid. Yeah, I
Yeah.
mean, we're working really closely with the health department in health section in UNICEF, because obviously we're talking about antenatal care services. So we're working very closely together for that. The next step is to, improve coordination amongst other UN agencies as well, but that's slightly above my pay grade at all times. But but absolutely, yeah, it's a very important question indeed.
Thanks, Astrid. That's great. Well, we've got another question that's come in from Emir, and the comment, first of all, is delivering MMS at the facility level is absolutely a positive step from a health system strengthening perspective, but it doesn't necessarily address the needs of women who deliver at home and who don't access ANC services. What strategies can we implement to reach them effectively? And maybe I can start just on that, Emily, because I was rereading the report, and there was some really nice examples, particularly from Somalia and Madagascar, of where community health workers had been used at the community level, but that was particularly for mobilization, for outreach and encouraging women to attend antenatal care services, and the community health workers weren't necessarily distributing the MMS at the household level. So it's a very interesting question. I don't know if that is something being considered in the acceleration plan, for example.
Well, in the research project that you mentioned earlier, it was called Improving, and it's around improving, women's health in general, pregnant women, that was implemented in 4 different countries, Burkina Faso, Bangladesh, Tanzania, and Madagascar. And in Madagascar, we actually trialed having community health workers give MMS from the health post. They didn't take it to the women's houses, but they delivered it from the health post, because it's very difficult in Madagascar to access health facilities. It could be 5 hours walk across the mountains to get to them. So we asked the community health workers to we obviously train them up, but to give counselling and to then also refer them on to antenatal care services. But they delivered their MMS, and it was very successful in early identification of pregnancy, because MMS is going to be more effective the earlier we can give it in the pregnancy, obviously. And if you're just giving it in the 3rd trimester, it's not going to have nearly as much effect. So using community health workers has been really effective, and it's something that we're hoping to replicate in other countries. Obviously, that's a decision of each government whether they are willing to task shift down to community health workers or not. But certainly the results from the research was very encouraging.
Thank you. We've got 3 more questions. I wonder if we can spend a minute on each so we can try and get through them. One is from Naveen. Is there any donor condition that you're aware of for MMS? So when low and middle income country governments are receiving MMS, are there any conditions that you know of?
I mean, it depends on the donor. All donors have conditionalities attached to them. So it slightly depends on the donor. I don't think there's a blanket conditionality for low and middle income countries as opposed to higher income countries. The funding that we've managed to fundraise so far through the acceleration plan, and what we're hoping to also carry on fundraising, sometimes because the CNF, the Child Nutrition Fund, is part of the GAP, the Global Action Plan on Child Wasting, which of course women are part of, because of the prevention of wasting in young children. So sometimes some of the donors will only want to be funding the GAP countries. There's 23 GAP countries. We've got 16 countries. I think the overlap is 9 between them. So sometimes we need to funnel the funds through to the GAP countries for donors who particularly want to fund GAP countries. Other donors particularly want to fund countries that are in their regions of geopolitical interest. So it's more about what specific conditionalities each donor has. But what we're trying to do is make sure that each of the 16 countries will get sufficient programmatic funds, because as many of you know, there's been a large donation of supplies, so there'll be sufficient supplies for all 16 million women, but we are still fundraising for programmatic funds, and we're trying to make sure each country gets what they need when they need it. Quite the challenge, as you can imagine, but we're working on it. Yeah.
Thank you. I'm going to call on Philomena. There's a question in the chat on iron content in supplements. And I wondered if you'd be able to reply to that directly. Philomena is part of Healthy Mothers, Healthy Babies Consortium and the MMS Technical Advisory Group. So I wonder whether, whilst we continue chatting, Philomena, maybe you could type the response to that question in the chat as I go to, thank you. Just so we can try and get to another couple of questions. Emily, we had a question on indicators, really something close to your heart. I know you've been spending a lot of time. What indicators do we need to measure and monitor during the scale up to increase evidence-based programming? You've been looking at this within UNICEF, I know. Anything you can share with us at this stage?
Yes, well, it's still very much a work in progress. I think coverage and adherence are really important indicators, but we're also really trying to look at, I mean, the challenge we have is that we have to use indicators or data that is already collected. If we introduce new indicators of collection, then there's the whole process that it's got to get into their health management information system at country level. So I've been talking a lot with the health advisor at UNICEF, and it is quite difficult because it's quite macro level information you can get around antenatal care. We'd like much more information than is readily available, but to get that, you need to do a more in-depth study in a particular country or a particular district to look at, facility level and individual level. So we're a little bit constrained with what is already collected, but that's also what we have to work with.
Right.
So we work within what's collected for the routine data, and then what we're thinking about is how we can best do like not necessarily short, but deeper dives in selected places to get a bit more information on how much we would need and from how many countries and all of that sort of thing. So as I say, it's a work in progress, but at the moment it's just what routine data is available. Yeah.
Thank you. We've got time for one more question, and maybe to share the load, I can take this one. It's from Nikki. How much of a barrier is it that WHO still only recommend MMS in certain settings, i.e. Research settings? Has this prevented as much interest and uptake from governments? So I can just speak to that in terms of the key informants who we spoke to on the report. For some governments that had a very strong role in domestic crisis management, it really was a barrier because they wanted MMS to be in national protocols and policies so that when scale up surges is needed, there's a clear policy where MMS can be used. There were some examples where what didn't seem to be an issue, and Somalia comes to mind, where MMS isn't actually in the national policy as of now, but there is widespread MMS programming in humanitarian contexts. So a bit of a mixed bag, but I think overall that there really was a call coming through strongly for national policies to be able to list MMS as part of a package of interventions for ANC, and having that explicitly in WHO guidelines would be very useful. And I think with that, I can see we're at time, and I'd like to hand back to Martin. And Philomena has kindly replied to one of the questions in the chat, so thank you. And we'll endeavour to maybe answer questions we didn't get around to through yourself, Martin, if that's possible. So handing back to you.
Thank you very much, Phil and Emily, for such a nice discussion. I think it was very insightful. We've got a lot of questions in the chat and others also directly to us. What we always do is prepare responses to questions. And so if you want us to be able to send you responses directly, you can also email us your contact email and we will be able to reach you. This coffee and chai chat will be available as a recording on our channel, and so you can just view it later. We also sometimes try to curate the key messages as well, so that for those who have less time, don't have the time to go through the whole 45 minutes, and they can be able to just quickly get the key messages. There are a couple of links that were added in the chat that are links to the reports that were discussed from the various agencies. And so I encourage you to download them and familiarize yourself with them and see how, given your regional context, or how you can take advantage of these reports. Otherwise, mine is to thank you for making time to join us this morning, afternoon, evening, from wherever you may be. Until our next chat, which we will let you know through this same email chain. Thank you very much.
Thank you.